Dyspnea is the most prominent presenting symptom in people presenting with acute heart failure. And it has been a challenge up to now, particularly in trying to determine whether the patient gets hospitalized or not. Often it's the dyspnea that makes that decision for the doctor. And I am here with Professor Metra, who is an associate professor at the University of Brescia, Italy. And for our purposes here today, I should mention he is co-chair and member of the executive committee of the RELAX HF trial. So in this particular case, let's talk about a new drug and what's happening with RELAX HF. What are you presenting here at ESC?
Okay, the results of the main trial, which included more than 1,100 patients with acute heart failure, have been presented by my co-chair John Teerling from the University of San Francisco at the American Heart Association last year. And what I am presenting here at the outline clinical trial update session on next Monday is the subgroup analysis of the different pre-specified plus additional subgroups from this trial, and we assessed the interaction between each of the variables and the effects of serelexin on the primary, secondary endpoints, as well on cardiovascular mortality, which was a secondary efficacy endpoint, and all-cause mortality, which was a safety endpoint. And the main results, to summarize very quickly, is that there was homogeneity with respect of the favorable or the neutral effects of serelexin across the different subgroups. Therefore, dyspnea measured by the VAS area under the curve, which was significantly improved by serelexin compared with placebo, had the same response across all the different subgroups, and whereas similar results across the different subgroups were found with the Likert scale, which had showed a tendency to an improvement with serelexin, and with respect of rehospitalizations and deaths at 2 months, which were neutral because there was a decrease in mortality and an increase in hospitalization, both not significant but of the same magnitude. There was no difference. There were some statistically significant interactions with respect of the effects of serelexin on either cardiovascular and all-cause mortality, but they have to be interpreted with caution because of the low number of events and the high number of comparisons. Therefore, they may be due by chance, although some tendency may be interesting. There was a larger effect on mortality versus placebo in the older patients, the patients with no previous hospitalization for heart failure in the previous year, the patients not on beta blocker treatment at the time of admission. There was a tendency to a better effect also in the patients not on ACE inhibitors or mineralocorticoid antagonists. And this may all be consistent with a drug which is more active on the peripheral vasculature and on the peripheral mechanisms. But again, this has to be taken with extreme caution because of the low number of events. It's also very interesting, the opposite, that the effects on the subgroups defined based on baseline systolic blood pressure, and this might have been likely that the drug is more effective in the patients with a higher systolic blood pressure at baseline. In this case, I mean, the effects were completely homogeneous, the same magnitude independently from baseline systolic blood pressure. But of course, we included, because of the design of the trial, only patients with a systolic blood pressure larger than 125. Greater than 125. Also, time from presentation to randomization did not affect the results. And this is, again, interesting because we know that the winning aspect of our trial might have been that we enrolled patients within 16 hours from presentation to the hospital to randomization. Therefore, again, with this criterion, we probably selected an homogeneous group of patients, and at this level it doesn't make a lot of difference whether the patient is randomized between at 6 hours or 12 hours. Instead, if we had a larger interval, it would be different. Also, patients on nitrates had a similar benefit, although this subgroup was small, only 7% of all the patients, and also patients with preserved ejection fraction. We had pre-specified a cutoff of ejection fraction 40%. We had, I think, 35% of the patients with an ejection fraction larger than 40%. We had approximately 25% of the patients with an ejection fraction greater than 50%. And also these patients had the same response, favorable response to serelaxin with respect of both the dyspnea, visual analog scale, and with respect of mortality data.
So with the visual analog scale, I mean, what are you seeing when you give this to a patient? I mean, dyspnea is a really tough presenting symptom.
Yeah.
Clinically, what are you seeing? You give them the drug and what?
Okay. Well, dyspnea is very difficult to measure. It's a subjective measurement, but on the other hand, is the reason why the patient go to the hospital, and this is associated with poor outcome. With the visual analog scale, you simply give to the patient a piece of paper with a line and with 100 written to the top, 0 written to the bottom, and the patient has to sign its amount of dyspnea, right, with 100 as the most severe as possible and 0 no symptom. And so we measure this at different times during the first days of hospitalization, and you have a larger improvement with serelaxin compared with placebo. And being the study double-blind, I mean, it's a consistent finding.
Right. So what's next in terms of where this
what's
is going?
What's next is very exciting, at least for us. Well, first of all, the company has applied for approval of the drug, both with EMA in Europe and FDA in the United States. The drug has achieved the status of a breakthrough drug for FDA, which means an accelerated process of assessment. And from the more scientific point of view, we are just starting a large Relax AHF2 trial, which is going to enroll 6,000 and almost more than 6,500 patients, and with mortality as a primary endpoint. So we have acknowledged, and the company has acknowledged that the results of mortality are really a breakthrough, a major progress in the treatment of acute heart failure, but they needed to be confirmed and finally proven in a group of patients which should be large enough to be sure regarding the results. Today it can be interpreted as an index of sure safety, but of course things will be different if we can demonstrate that the drug can really decrease mortality with the 6 months of follow-up.